Thank you. So I think that meant that I'm a big nerd, is what all I heard from that, right? So I'm Dr. Briskie. I'm a co-owner of Colorado Surgical Institute. And through this process, we teach doctors how to learn implants without needing therapy later, right? How do you do implants? How do you integrate into your practice? How do you do full arches? How do you protect yourself from right, the local specialists? Make sure you have good perception. There's a lot to it. I opened my startup implant practice 2 years ago, as of next month. During my first year, I did 50 full arches. I was pretty proud of that. In the first 2 years, I was able to do 800 implants. Now, of that, I only had 6 spinners, so 6 implants that were less than 50 or 25 Newton centimeters of torque. And that's really, really important for your business. I think Dr. Dune in the past has calculated that the cost of one implant failing is you will lose profit on the next 4. So in my presentation, we're going to go over how to choose the right implant for the job. Okay, we're going to get a little nerdy here because I love being a little nerdy. I get a little bit clinical, so you guys can walk away with the same knowledge that I have. I want everyone to understand how to do cases the same way we do at Colorado Surgical Institute. So we're going to talk about choosing the right implant system. One platform, fewer parts, smoother workflow. How we're going to simplify your setup. What do you actually need for an implant surgery? What's your inventory? What implants will you stock? What healing abutment sizes, right? Of the room setup. What's your room going to look like? Helix versus drive. And we're going to talk about the style of the 2 different implants, which each one will be used for. It's very specific in terms of the thread design. And how drive implants are going to be your rescue implants. Drilling for torque. So we're going to talk about D1, D2, D3, D4 bone, how to spot it, but how to drill for it, right, in terms of the strategy that I want everyone to start looking at when you see these cases on your CT. And we're also going to show the new narrow implant, the 2.9, and the short helix implants, which is a tissue level implant. Very, very smart. And at the end, I'm going to show my restorative workflow. So I'm going to give you my lab slip that I use for all of my cases. And we're going to talk about some restorative pearls to make sure that things go really, really well. And we're going to show the new angled screw channel that Neodent has coming out from Unique, from Straumann. And it's a 25 angle correcting. So, one restorative platform across all implant types. The only one that does not have the same one is the Neodent narrow and the short helix, right? So a very big, very, very big portfolio here. And I think last weekend I saw one of my reps say that there were 296 different implant sizes throughout Neodent. That's absolutely amazing. And there are so many pieces and parts that you can use and you have at your disposal. That's why I love Neodent. So fewer parts, fewer mistakes, easy for your team plus the lab, because there's only one restorative size, right? We don't have a shelf full of 3 different platforms to confuse our staff or we're pulling the wrong products, right? Let's keep it simple. The ideal implant system checklist. Some of these things that you guys already know, right? Platform switch, internal indexation, which means that it's going to go in, it's going to rotate 5 different ways that you can pick. It's going to be a conical connection, less than 20 degrees. Neodent has a 16-degree Morse taper. And we're going to go into that in the next slide. Versatility, something that you can use for full arch, for singles, right? For something atrophied, zygos, right? Not pterygoids yet, but really want something then that's something small, something big, something for full arch, something for singles, right? It's all there. High initial torque. I think one of the complaints we get at our surgical institute is that the implants are almost too stable, right? That's a really good problem to have. So no spinners. Aggressive taper design and a cost consideration, right? We do not want to pay an astronomical amount of money as a GP. We need it to be affordable as well. GM connection, the Y. I saw this slide on a presentation once and I saved it. I really love this picture. The one on the very far right, it says internal hex connection. Now this has been, this connection has been multiplied and used probably hundreds and hundreds of times, right? This is a Zimmer, Nobel, Astra, right? The list goes on and on and on and on. The one on the way left is the Neodent GM connection. The one in the middle is the conical connection, right? Like a Neodent CM, the old implant system. So look at the two pictures on the right and look where the screw is. And if you look at the screw, you can see how you just have one screw goes all the way down here and all the way down here. And you look at the walls. So the security of this implant is coming from the screw, right? It's not actually coming from the entire internal surface. So on this slide here, you can see where there's no dead space. It's a way larger screw, right? It's just tighter fitting. So you're gonna get less of a micro gap, right? And less broken parts with this connection. This is why this is such a great implant. Very, very, very important slide. So the best implant system won't fix a rushed hand or a closed mind, right? I think during teaching, Dr. Dune and myself will try to spot any doctors who they don't have enough humility, right, or humbleness to them. And being humble will bring very, very fast learning throughout your entire life. And Dr. J will concentrate on those students, humbling them and really giving the people some extra time. And what I really, really love about Neodent is this Growth Summit is so amazing. We have really like-minded people in a room willing to learn. When we go to a local dental society, I think a lot of the time people will posture and they're like, hey, do you implants? Like, yeah, I already do implants. We're like, whoa, all right, well, I guess I'm not gonna talk to you, right? So this is a very awesome environment that's conducive to learning. This is why I love wearing the color purple. It's about having humility to keep improving even when things go right? I measure myself in terms of the failures is what I do. I rarely will brag about a case. And great clinicians don't blame their tools, they sharpen their skills, right? Oh my gosh, I don't know how many CE hours I've spent over the past 10 years. It's probably over 800 CE hours at this point. Always learning, always changing, always evolving. What is the inventory that we should keep? So if I was restarting today, with the knowledge I know today, what would I stock? What surgical instruments would I set up? And how would I set my room up? So looking at this slide, I think from this morning, I think Mark Costas would probably look at it and be like, hey, that's a lot of expensive stuff in that drawer, right? So I'm not saying stock what I do, right? I'll stock things for 99% of cases from a single to a zygoma, right? But I want everyone to understand what I want you to stock in your own practices. So don't overspend. Start with the essentials and scale as needed. Track your usage, establish surgical workflows that allow you to set implant quantity minimums. So think about it like a carpule of composite or how much Scotch Bond you have in your practice, right? I set mine as 2 Scotch Bond and I set a minimum for my carpules of composite. I do the same thing for my implants. So with my surgical workflows, for example, if I was doing an all-in-X, the most common sizes that I use are a 4.3 by 13, a 4 by 11.5, and a 5 by 8. Now, I have a specific strategy when I go into the surgeries. If I don't have stability, I can upsize to a different one, but I already have that implant in stock, right? So I'm always planning my cases and having my surgical workflows so that way if something does happen, I can bail myself out of 99% of situations. Now, if I was to stock only 3 implants in the practice, I would stock a 5 by 8, a 4.3 by 10, and a 3.5 by 11.5. Those 3 implants have very, very similar bone to implant contact when you measure the diameters. So if you place one of those 3 and you try to take it out, it's not coming out, right? And now if you put a very smaller implant in, like a 5.5 or less, yes, that implant could come out. So part of the reason I love this company is the implants will integrate very well, but they're not also too big to the point where you can't take them out later, right? So 3 implants to stock, those are really 3 safe sizes. Now, if I was starting today, this is what I'd stock to tackle 99% of cases. On the left is going to be the implants. There's about 22 of them, and healing abutments and cover screws on the right. So let's go through this list. It's very important. So the ones in bold that say Helix, those are going to be used in 99% of my cases, okay? 3.5 by 11.5, 3.5 by 13, 4.3 by 8, 4.3 by 10, 4.3 by 11.5, 4.3 by 13, and then 5 by 8, 5 by 10. Those I would stock 2 of each of one of those, okay? The ones that are not in bold, those are the ones that are more like our rescue implants. You want to have something shorter and more narrow, and something also to upsize to, just in case you need to bail out. So I will stock 1 3.5 by 8, 1 3.5 by 10, a 4 by 7 Titamax. This implant's a really cool one. I'll show you guys the implant designs here in a second, but it's a straight walled implant. And I use this on my right? 7mm implant, because the Helix and Drive, they come in minimum as an 8. And then for the Drive sizes, these are our rescue implants that I like to call them. I stock a 5 by 8 Drive and a 5 by 10 Drive. So this is something also you're going to use to upsize. As far as healing abutments go, I would do cover screws. I'm not the biggest fan of the 2mm tall cover screws. I think sometimes we can get tissue openings, so I want you all to be safe here and order the flats. A 3.3 by 4.5, keep 1. You never know where you're going to use it for a lower incisor or upper lateral if there just is not a lot of space. The most common ones I use are 4.5 by 3.5. So the first is the width, the second number is the height. And I use a 5.5 by 3.5. Those are the 2 most common ones I place. Because if you follow the biological rules, like a zero bone loss concepts, the 3.5mm height is going to be your average. The custom healing abutments are amazing to use. They come in a white peak material. It's a very, very hard structure. I only keep the 7s because they have a 5.5 and a 7. I keep the 7 because it's bigger and I can trim it with a burr, right? So you take a chamfer burr and you trim it to the size of the actual hole or the shape of the tooth. This is especially useful in canines or premolars, right? Teeth that you want that shape without the recession. So I'll keep both sizes, a 7, 3.5, and a 7 by 4.5. Now organize it. How do I organize my stuff? I keep little bookshelf dividers, and I put it in a little closet. And this is really, really easy to inventory. So have a little sheet, and my DAs will go through and check which ones that we need to order every 2 weeks that are missing from my inventory. So I'm not saying buy 60 implants, right, like I do, but I need 60 implants due to the amount of cases that I tackle. So part of the growth is we start to accumulate the amount of things that we need, right? Just as our practice is growing, don't immediately buy 60 implants. Start with some of the sizes that I suggest, and as your practice grows, you're going to also buy more inventory, right? And it's important to always remember that you need an implant that could be 1 size longer than what you picked, right? 1 size wider. Also, keep in mind something you may need is something 1 size shorter or 1 size more narrow, right? So every single time you go into a surgery, don't pick the biggest implant for that surgical site. You want to pick something that is slightly smaller, right? So you have something to bail yourself out. And keeping Drive implants for various reasons. The biggest thing is patients pay a lot of money, right? And we never want to abort an implant placement due to the lack of our inventory, right? There's nothing more embarrassing than that. Of just saying, hey, I actually don't have that size. I could have placed it, I don't have that size. So now how many post-op appointments do you have tagged along to that appointment because we didn't have the proper inventory, right? So at least try to keep those same 22 implants that I recommend. And you can tackle almost every case. Next one, in terms of organization, is going to be healing abutments and cover screws. So just above my implant stock, I keep these little Simplastics dividers. These ones are, I think, are 5.5 inches tall, and they fit the Neodent casing perfect. I love this. So my bottom row is full of multi-unit sizes, and I really only use a 2.5 height. So it's like a 17 2.5, 30 2.5, straight 2.5. And then the ones right here, I keep extra drivers. And these are going to be things that are in our like prosthetic kit, right? Screwdrivers, a couple random short drivers like that. The one right here, I'm going to keep also some implant drivers. So the ones that go onto the torque wrench or go onto the implant handpiece. It's important to always stock one long and one short of each of those, right? The latch, one for the latch and one for the torque wrench, just as a backup. What if you drop it on the ground? What if something crazy happens? Our assistants sometimes will lose stuff, and that's okay. So also make sure you make really good friends with your reps in the area, because they can help you replace these items, right? So I have really good relationships with my reps. Now up here, I stock quite a few different sizes in terms of my healing abutments, but the main ones I use are the 4.5 and 5.5 width and the 3.5 height, or like the 7, the custom healing abutments, the one that have a white material. Those things are amazing. This is a picture of the Simplastic ones, the ones that I bought. And these little trays I'll also put on the side right here, and you can stock maybe one set of extra drills, right? What if you lose a drill and you don't have it for the surgery day? So I'll keep one 2.0, 3.5, right? 4.0, 4.3, and a 5. I'll keep one of each just in case it turns rusty or if I lose it. So how do you set up your implant room? Dr. June went into this in depth. So I'm only going to talk about the one thing that I like the best, which is my implant box of teeth. I love this box. I carry this everywhere with me when I go around the practice. And this is actually a denture that I made back in dental school. And so it's a key. I love having it in the box. It's pretty cool. You can show patients. This is a snap-in teeth. It's a model from Straumann. This is an example of a printed prosthetic for an FP1, an FP2, and an FP3 that I keep. This is a model of it also, a Neodent Straumann model. This is the fixed arch that goes on top of it. This one goes on top of that one. And then over here we have gum shades. Patients, when they see those tabs, they're like, oh, that's cool. This is actually a really custom process, right? You can match the teeth colors and the gum colors. These are two different night guards that I print in-house. I keep one for pain patients, and I have called a Freedom Appliance. And then I have another standard night guard that I print. These are all printable off of a Keystone soft material on my P20 printer. This is an implant if a patient is brave enough to hold it, right? It's kind of scary holding an implant that's gonna go in your mouth. And these are veneers if a patient wants to see what those look like. And I have a milled denture right there, which is cool. It's about 8 times stronger than a traditional denture. And I use it as a selling point. I say, hey, I actually do not do regular dentures anymore. I only do mills. They're 8 times stronger. Instead of powder, liquid, where you stack them up together like a denture is, this is made from one solid block. This does not cost any more money, but we offer a better product here in this practice. So that way, if they go somewhere else, they're already paranoid, right? They're like a traditional denture, like, whoa, well, Dr. Briskie doesn't do that, right? And at the bottom, we have a ton of different shapes, sizes of zirconia arches and lots of colors. So I have a BL1, BL2, a couple other ones here. Also important to remember, don't make your patients picky. So don't tell them they can choose any one of these. I usually will help them choose it for them and say, this color looks really good on you, let's do that, right? So you don't want to encourage your patients to be too picky at the same time. This is my room. The implant, that tooth box is always in the room. And my TV is right in front of the patient. This is a 50-inch. And I have a Vautech software, which I really love because you can scribble on it, kind of like this little marker here. You can scribble on the CT or the pano and show your patients where the bone is, where is the sinus, where are the defects, right? And also show the CT gets pulled up on that same thing. And it's a really awesome patient experience tool. You wouldn't believe the amount of patients that have never seen their own CT. And we've seen it so many hundreds of times, right? But a patient who sees this, they think it's the coolest thing ever, right? And I tell them that this takes the guesswork out of dentistry. Here at this practice, there are no surprises, right? Because I can see what's going on. So my job is to make sure that I protect your finances. This is a picture of my implant setup. This would be for a full arch. And the first thing that you can see are some of these little tools. I have this little bench, and this bench, right? This one right here goes underneath that one. So it kind of folds right underneath it. So I'm already collapsing items and having some space savings. This one will be in the corner, usually just sitting there. Lots of other equipment, right? You have your IV monitor, you have your pole, you have implant motor. Still my favorite is the NSK, the Straumann one, it never breaks. And over here we have PRF supplies, and I think this entire PRF setup costs about $500. So if you guys ever want to get on the phone with us, just ask us what we use. We'd be happy to tell you. This is a drug box that's mounted to the wall. And I have my iCam. This picture almost gives me anxiety because I see my iCam sitting on the edge of that thing. And I'm like, oh my gosh, there's a car about to fall off. The price of a car about to fall off that bench there. So I probably would have put that a little bit more in the center. But big surgery op, right? And remember, in the same op is where I have locking cabinets. And those locking cabinets is where I keep all my biologics. And my implants are locked away every day. So before the weekend, before the night, we lock the cabinet. So do not overspend. I hate spending a ton of money on instruments. There's only a few instruments I would buy that are actually worth it in terms of buying something a little bit more expensive. So let's go through this list. We have, from the left, we have an Explorer, a mirror, right? And a mirror we're never going to use, right? Because it's not really a surgery item. It's just something to peek inside to see if you can find a root tip, right? And we have a tissue forceps. The tissue forceps is always in my left hand during surgery days. When the tissue forceps not in my hand, I think my phone is usually in my left hand, right? So it's just an instrument you want to always have on you and always in your hand to be very delicate with your procedures. That is actually a Neodent needle holder. It's really nice. It's rounded. It feels really strong. So it's something that I bought from them because I thought it was cool. It has Neodent on it, and it's a nice piece of equipment. And scissors. These are from eBay. This is from eBay. This is from eBay. These are actually from eBay too. So it's a TC tip on it, German stainless steel. It's like 20 bucks. So I've had the same ones for about 2 years now. And then over here, the only items that I would really recommend spending a little bit of extra money, right, not something crazy, is going to be your root tip pick, your Lucas curette, and my personal favorite instrument ever is the Boozer elevator. This is my favorite instrument ever. The tip on this is 5 millimeters as opposed to the periosteal elevator is 7. Imagine doing a surgery with a Boozer versus the periosteal. It feels like you're using your thumb to do surgery with the periosteal versus something that's a little bit more precise. So how do we have less pain on our incisions, right? How do we make a cleaner flap? How do we make sure that our flaps do not look like pulled pork by the time we're done with them, right? Because we're mangling it so much. So I really, really advise everyone to use this instrument. It's my favorite one. And then we have syringes. I always keep 2. I like to pass instruments back and forth with my DAs. I pass the syringe and I pass it back, right? And 2 Minnesota retractors as well. Those, you can tell they've been used very nicely. That means a well-worn instrument has been a really nicely used one, right? So don't overspend. Implant selection, Grand Morse, GM. GM Helix versus the GM Drive. I want you to understand the thread design in terms of why it cuts, but also why it densifies, depending upon the implant. I want you to select the right implant based on the job, whether it's D1, D2, D3, D4 bone. And I want to compare the thread designs in terms of its impact on the stability that you're going to achieve. So Helix, everyday workhorse. I use this for 99% of my cases, and it's a tapered implant, so let's look at it on the screen. Tapered implant, it's self-drilling, self-tapping. So look at the tip of this. We have triangular threads that are meant to cut. And the triangle threads go from here to about here, almost a third of the way in. So as soon as that implant goes in, it's pulled in, right? The implant pulls it inside that hole. Now, what's awesome is when this implant was designed, they were very smart, and they made the threads the actual like a trapezoidal shape about halfway up. So it turns from triangular to trapezoidal. The hard part about a lot of implant companies are the entire implants are knife edged or cutting. How are you going to get stability on 99% of your cases if the implant is just not designed to do that, right? And what's cool about the everyday workhorse one of the Helix is it's designed to cut but also get densifying, right? So really, really awesome idea. I will use this on every single case. Now the only type of case that this is not meant for is the Helix 6.0 and 7.0 diameter ones. Those are not meant for D1, D2, right? Those are really D4 bone cases. That's just too big of an implant. So use this one for a majority of cases. Now the drive implant, this is one of my favorite implants of the company. This has saved my butt so many times. I'd say over the past 600 arches, there's probably only been maybe 3 cases that I haven't loaded, and that's because of also this implant, right? And there's lots of other little theories we can go into. Now, if you look at the implant design, the tip of it is a rounded apex, okay? The first flute is really a cutting, and then it goes right into these square format of the thread designs. So this implant was made to condense bone, right? To densify and condense bone. So I only use this implant in D4 bone cases or to upsize is what I do, right? So that's my rescue implant in all these cases. And currently in my practice, I'll stock that one in, I actually have it in a 3.5 as a rescue, because some cases they just don't have enough bone in general. And then I'll stock every size in a 5.0. So I'll go 5.8, 10, 11.5, and a 13. Oh my gosh, how many times that I have pulled out like a 5x13 drive, and you're able to get 45 Newton centimeters of stability, and patient has teeth the next day, right, in a fixed full arch. So, and then what is the cost of us not doing steps like this, right? Imagine if we just drilled a hole, we get spinners, and we start sending our patients home, right? No, like I want us all to really think about how do you get stability in every situation. Stability is identified as 35 Newton centimeters is what I recommend. Because that's when you can immediately load an implant, is at 35 Newton centimeters. So drilling for torque, we're going to talk about each of the bone scenarios, where it's D1, D2, D3, or D4. And then we're going to talk about, do spinners heal, right? That's always a question that I would get. And is pressure necrosis a myth, right? Is this real? Is it a real thing that is actually experienced? So in the picture we have on the left is D1, in the middle is D2, D3. It's hard to tell the difference between D2, D3 because it really just looks like a sandwich coating on the outside where the cortical bone is. On the inside, it looks a mixture of something, right? Something white and something dark. And D4 bone, these are the ones I get nervous of when I see, right? And they're actually pretty rare. You see just a dark hole and a dark abyss, right, that your implant can sink into. So we'll talk about some strategies with this implant. D1 bone. The first thing is to observe the CT. What color is the CT, right? Is it white or is it dark? Let's just make a generalization of what's going on. Neodent says 800 to 1200 RPMs and lots of irrigation, which is what I would do. It's important to drill to the plus size burr in a lot of these situations. So the twist burr undersizes your osteotomy already by 0.7 millimeters. That's quite a bit, right, already. So in a lot of these D1 bone cases, I'll also use the plus size burr. The plus size burr is going to undersize your osteotomy by 0.3. So a true D1 bone case, I would say we almost always use a plus size burr, right? We don't want to just try to jam the implant down. We can break implant parts. Not good, bad day. So it's also important to identify what is implant depth. What's the depth of your osteotomy? The depth is, for myself, is classified as the implant plus the biological width. So that's about 2 to 3 millimeters. If you're placing an 8 millimeter implant, the minimum you should drill to is about a 10, okay, in my hands. So when we have a lot of our courses on the weekends, I get so excited because it's so much fun to teach this stuff. And you go into a room and the doc says, hey, I got a spinner. I'm like, oh, really? Did you? Let's look at the case. Half the time, it's actually D1 bone. So there's such thing as a D1 bone spinner. That just means that while you're drilling, we didn't drill deep enough. The implant hits a rock stop at the bottom of that osteotomy and it starts spinning. What does it do when it starts spinning? It starts churning up the bone, and now we need a way bigger implant in order to even have a successful outcome for that case, right? So it's very, very important. If you start to see your implant lose stability, stop right away, and let's try to figure out why this happened. I'll take it out. The first thing that I check is the implant depth. What did I drill to for the depth? It's usually the depth that's the issue here. Then I'll put the implant right back in. Now, when you have very high torque, what I'll do with the torque wrench is I'll do 3 turns in, and then I'll do 2 turns out. I'll kind of keep doing that slow motion until the implant seats all the way. So, speaking of high torque, right? Now, if you are doing that and you leave high torque on the ridge, let's say it's at 45 Newton centimeters or up to 60, right? Because this is only warranted to go 60 Newton centimeters. Will you get bone loss like this picture, right? That's the question. Is pressure necrosis a myth? Does high insertion torque affect implant success? And there's several articles that show there's no significant effect on implant survival, there's no significant effect on marginal bone loss, and the high insertion torque needed to actually cause necrosis, pressure necrosis, is over 176 Newton centimeters. What would happen if we reached that? The implant would flower, right? The implant would flower, or your driver would break. The first step thing that would happen would be the implant driver would break. Then the second step would be the implant would actually flower. So I don't think both of those could actually happen. So the real question is this pressure necrosis, or is this a lack of biological width, right? That's my personal belief. Let's back up one slide. Now we'll look at this x-ray. So the few things that would have went wrong in this scenario, right? We've seen these cases posted all the time on Facebook, like, hey, I put this implant in, and I got bone loss within the first few weeks, right? We should all know what this answer is after this. If the implants were placed below the bone instead of equal with the crest, the biology would have not had remodeled, right? So if you leave an implant even with the crest, we need a minimum biological width of 3 to 4 millimeters, right? And that needs the amount of bone or tissue above the surface of that implant. If we do not have that, the body will remodel it, okay? So that's why we always place implants minimum 1 millimeter below the bone, so we do not get that type of remodeling happening. And because this happens so often, we just associate, right, pressure necrosis as being us placing an implant equal with the crest, right? I hope that makes sense with everyone here. Another thing which is really interesting, I see this a lot, look where the tissue is. You may be able to see like a fine little outcome. See where the tissue is right here? It's almost above the healing abutment. So two things actually I think happened with this one. I think it got a soft tissue infection because the tissue grew above the healing abutment. Guess what would happen if the tissue is above the healing abutment? There's going to be bacteria that's uncleansable. So a lot of these cases, I don't use the 2.5 height very often. It's a little bit more rare. I'll use something erring on the side of slightly higher, right? So the healing abutment will sit at the level of the tissue or slightly above it. That's why we don't have a lot of infection gathering and bacteria around that healing abutment. Drilling for torque. What about D2 and D3 bone? What do we do in these scenarios? So it's important to decipher between the two. Now this part does take time because having our hands feel the difference between the two actually will take a little bit of time. You actually have to feel the bone in these scenarios. And I would definitely consider undersizing your osteotomy in these cases always by about 1, all right? You can always drill more, right? You can always take it out and you can always drill more. And I would say plan for upsizing the implant if needed, and make sure you have that implant in your stock and in your inventory, right? You have it there in the day. That means it's a successful game plan. If we plan for something and that happened, that's a successful game plan. But it's also a successful game plan if we stock that other implant we needed. So the goal is 35 Newton centimeters. That's the best practices that we believe in at CSI. If you can immediately load the implant, I would say it's a really good objective way to know that the implant is very stable. Now, if you place an implant in the setting that Neodent also recommends, right, in terms of the speed that implant needs to go in is 35 RPMs, right? So every implant needs to go in at 35 RPMs for the Helix. Now, if you set the motor to bottom out at 30 Newton centimeters, there's 3 things that are going to happen. When you put the implant in with your driver, with your motor, if it stops 4 millimeters above the crest, the chances of you getting that implant down below the bone and not violating those like over 60 Newton centimeters, it's not going to happen, right? So take it out. Take out the implant, drill, check your depth first, right? Check your depth, then upsize your burr, and then put it right back in, okay? And if the implant stops 1 to 2 millimeters above the crest, I would say at that point, that's pretty successful. I would just torque the implant down the rest of the way. And the theory is, for a ballpark here is, for every millimeter that you sink an implant, you're gonna expect at least 10 Newton centimeters in gain of that implant, okay? That's really more meant for like straight walled implants, but the theory still holds true, right? If you have an implant that stops above the bone by 1 millimeter, I'm like, yes, right? Like, that's great. That's what I wanted. Because by the time you drop the implant down, you're going to be at 45. And if the implant doesn't stop, right, keeps going, and you're just below the bone, just stop all the way, right? Because what if we misinterpreted this as D4 bone? The implant could sink down, and we could lose it, right? So something that turns equicostal or slightly below the bone, I stop and I remove it and I assess what's going on, okay? Just to make sure we're safe here. Because this whole time, remember, we stopped at 30 Newton centimeters. So if the implant is still not stable, which is rare with Neodent ones, and it's below the bone, we need to upsize. D4 bone, these are the scariest scenarios, oh my gosh. Now, it's really important to observe this, and we just look at the darkness. Like, oh man, this could be a fun one, right? And we have to anticipate undersizing minimally 1 burr, sometimes 2, right? Now, Neodent was very, very smart when they made their protocols. They actually put their manufacturer setting down to saying 500 to 800. They already understand, right? They know that we have to slow it down because we need to feel the bone, and we don't want to over drill, right? There's something called a push test. Now, if you look at the cortex, the cortex of right here, there's a cortex of bone, right? Now, what happens once we break that cortex? You just enter soft bone, right? So that's why it's important to do a push test, right? So after you break the cortex, push your burr. And a lot of the time you'll notice it actually just goes right in, right? And if it does, we're done drilling, right? We don't need to use that burr because the burr has already been used by us just pushing it in. And this happens so often in full arches. Now the goal is to just increase the amount of bone touching your implant, right? So if you drill, the bone's gone, right? We're not getting stability now because our goal is going to be to densify. And definitely use some carefulness here in terms of taking the implant deeper than the thickness of the cortex. So if you're placing the implant, it's important to leave the implant almost even with, not even with the crest, but maybe 0.5 millimeter below the crest, all right? Or like just enough to where the implant still has stability. So when we're putting these implants in, it's important to really watch your torque wrench, right? Take the torque wrench and see when it starts to dip. Now, once it goes from 35 to 25, you're like, ooh, man, like, all right, let's reassess where we are, right? And a really interesting way that I have found it is placing a Neodent short Helix implant. It's a tissue level implant. I'll show you the design in a second. A lot of these scenarios all upsized from a 5x8 to a 5x8.5 short Helix because the threads of that implant can be left equal with the bone, right? So we will not get the remodeling that you normally would if you left this implant even with the bone, right? So the goal is bone stability, 0 bone loss, and using our implants that we have in hand. So, do spinners heal? Is there a correlation between implant torque and osseointegration? Now, primary stability is an important condition for obtaining implant osseointegration, right? It's a very objective way. If an implant is stable, we have a good chance that it's going to become stable later. A higher bone-to-implant contact will promote bone ingrowth and will reduce the risk of fibrous encapsulation. And research says micromovements in excess of 150 micrometers can lead to fibrous encapsulation, right? So this just shows that we want more bone around the implant, right? So let's all think about, in terms of the drilling, undersizing osteotomies, doing a push test, and using the correct implant for the job, right? Most of these cases are going to be with a 5x8 or 5x10 drive implant, with the possibility of upsizing to like a short Helix, which I'll show you in a second. It's a pretty cool implant. Narrow implants. They came out with a 2.9. Thank God, it's such a great tool here. It's actually a very aggressive implant too, because there's a combination of some triangular threads here that you're seeing and actually some square. So it's actually more stable than you think. I tried to undersize this a little bit too much, the couple cases I did, and it was too stable. I had to take the implant out and put a little bit bigger burr. But same thought process, right? If your implant is 2.9, you can't upsize this, right? You pick this implant because you already have a narrow dimension, mesodistally and buccolingually, right? So it's very important to slowly put this implant into the correct dimensions and not over torque it at the same time. In cases that you pick this, it would be more congenitally missing laterals, right? Something where the bone is less than 5.9 millimeters, right? Where you're not going to squeeze something in. Here's a case. This is actually one of my reps from the offices. He sells some parts and does some maintenance, and this is his teeth, so I was a little nervous on this one. But look at this case. He hasn't had teeth since he was a little kid. And look at those buccal concavities there. Look how deficient this is. He went to a ton of different consults. He ended up finding me. He said, hey, Briskie, I know you teach. Could you do this? I said, yes, sir. One surgery, right? So on this one, it was a fun one. We flapped it. I placed the 2.9 narrows, and these are ones where you can't miss, right? So you want to upsize, go slow, get the implant in correctly. And I augmented the buccal with a volume stable collagen matrix. So that means it's an artificial graft. And these will turn right into connective tissue, which is awesome. So it's an alternative to bone grafting. So volume stable collagen matrix, very, very excellent product to use. Use this on the front of a lot of implants or deficiencies on front teeth to just establish the ideal contour of the biology that I'm looking for. And you can just see even at the 8-week mark, looks pretty good. We got a really big recovery here. And it was just that surgery, right? I think that's a pretty successful win. We have a 2.9 millimeter implant that's screw retained now, right? It's a really stable implant. It went really nice, got good stability. And I was able to put some custom healing abutments on here. And I restored that one actually next week. So I'm actually excited to see this guy. Picture's gonna look awesome. So the short Helix implant, this is a new one, it's a very new implant. This one's a little bit different as well. It has a transmucosal collar and it's smooth surface, right? So it's gonna create a very stable amount of biology and it's optimized for lower bacterial adhesion. Really interesting implant. Let's break it down a little bit more. It's very good for cases of bone atrophy. So if you do not want to do a sinus lift, right, or you have more of a D4 bone, this implant is a very good implant for that. It's an alternative to the grafting or sinus lifts. I'll show you some cases in just a second. Now, it's important to remember the implant length of 4 and 5.5 heights are contraindicated for single use, right, for overdentures. So that's going to be the 7. And those that you just want to splint, right? If you're going to put some 5.5s in, they need to be splinted. Here's 2 different cases. One picture on the left is an edentulous ridge and a very soft bone. So if you have soft bone, you can only go so much. We picked the 7 millimeter, and the implant is aggressive enough to grab the outer cortexes of the bone, right? So it can get security because it's grabbing the outside. And you can place this implant even with the crest, right? So in cases where you just do not have a lot of running room to sink an implant, placing this implant even with the crest, you get excellent healing. And this is a picture, I think it was 10 days after surgery. It's already looking amazing. Another case on the right-hand side, same thing. The bone was very up and down and canted, and we didn't want to do bone grafting. So in this one, I elected to do a tissue-level implant, and there's really good stability, and that transmucosal collar allowed the soft tissue to heal very nicely. So excellent implant to upsize in D4 bone for bone atrophy cases in the posterior ridge, right? And also as an alternative to vertical, like bone grafting, right? So you have these vertical defects. Angled screw channel. This is a new thing that Neodent has just about to come out with. And it's from the Straumann unique platform or a portfolio. So it's an angled screw channel, and it has 25 degrees of divergence repositioning. It's pretty cool. And then with these ones, you can scan it. You can choose to design it, or the lab designs it, and then it gets milled. So it's very customized. Here's a case showing that an angled screw channel. There's a missing number 9. Took the tooth out, 1 surgery. Now, this one I did use a 7 by 3.5. And I actually put a little bit of composite on the front side of it just to push the tissue a little bit out to maintain those contours of where the gum tissue needs to be. And then we restored it later with an angled screw channel. So how do we restore implants predictably, right? What's the emergence profile that we're looking for? what subgingival materials do we want, what supragingival materials do we want, and I'm going to give you guys my lab script. So we're looking for a gradual emergence, okay, and a more narrow emergence. A wider divergence will start to apically displace the soft tissue outwards and upwards, right, causing a decreased blood supply, leading to bone loss. So, and these narrow and more gradual emergence is going to be extremely important to keep that bone maintenance. Now, subgingivally, zirconia is the most biocompatible material, right? Has the least amount of bacterial adhesion. And for these, we only ask for polished, right? There should not be any ceramic added to this material subgingivally. The body does not like that. It only likes the polished zirconia, smooth surface. Supragingivally, the best restorative material to hold up to occlusal forces is lithium disilicate, right? But that's more expensive. So I would definitely recommend doing a monolithic zirconia restoration, polished below the tissue, and above the tissue, you can use ceramic to do different color changes if you'd like. And if you want to have the best prosthetic, that's when we add lithium disilicate on the incisal edges of the occlusal table to resist those occlusal changes and forces. So lab communication error, this is one of my cases that I did incorrectly. So I took the impression like always, submitted it, and I get this back. I'm like, uh-oh, what did I do wrong here? So the bum is not seating. We have the wrong abutment height selected. Now, it's important to realize that the lab does not know what type of implant we placed, right? Just because we write Neodent GM, they may not know if the implant is placed equal with the bone, above the bone, or below the bone, right? So we need to include some pictures. And in the lab script, we're also going to be writing that for a more narrow and gradual emergence. And I'll actually print off a photo of the x-ray, and I'll scribble on it what I want it to look like little color markings, and then I'll show that with the case, just so they just have a grand idea of what I would like to achieve. And I'll also submit an x-ray, which I'll show you here in a second. So lab, they just don't understand. They don't understand if this is an internal hex or this is a deep conical implant, right? And we're going to help them understand it each time. This is an article that just came out a few weeks ago, I think it was in February, and it breaks down the link between abutment configuration and marginal bone loss in subcrestally placed posterior implants. And really all this article says, it shows the importance of, in subcrestal or crestal placement, profile angles within 2 millimeters of the bone crest were significantly correlated with bone loss. It says it matters, right? And they break it down. And having the implant connection point where the crown comes is important to have that minimally 1.5 millimeters from the bone crest, right? So that junction needs to be elevated. So too short of a tie base in these cases or custom abutment leads to bone loss, right? Things we have to show our lab. So lab prescription, what we do for restoration success. We want to write a clear, detailed lab prescription. We want to avoid common lab communication pitfalls. Building a partnership. I actually wrote a Google review for my lab. For every lab that I like, I write a Google review, and I tell one of their CEOs, hey, I wrote a Google lab review for you guys. You guys are awesome. Thank you so much. Because I want to have a gold star in my account, right? I don't want to be known as the doctor who calls the lab and yells. I bet you they talk about that stuff. And speak the same language, right? We speak a language. Let's help them understand that language. So this is an implant I placed. How do we talk with the lab to restore this number 30? And what we say is, please fabricate with broad, tight contacts with pinpoint ideal occlusion on the buccal cusps and in central groove of lowers, and pinpoint on the lingual cusps and central groove of uppers with no occlusion, and lateral excursus, right? Very, very important keywords to give the lab, right? And if they don't follow this, we can call them out on that, right? We want a screw-retained custom abutment, and I say Neodent implant, GM, you say the tooth number, with monolithic polished zirconia only, no glaze or ceramic subgingivally, and then you say the shade. Included are x-rays to see the proper emergence profile due to the depth of the implant to help in custom abutment fabrication, and we prefer a gradual and more narrow emergence. So I'll submit an x-ray of the healing abutment, or at least with the tie base in there, so the lab knows that it was seated all the way, right? And what's cool about this Neodent scan body, it's a metal-to-metal connection, right? We can see if it's not fitting perfectly, it shows up really clearly on the x-ray, which is great. And then I'll show a soft tissue scan without the healing abutment in there to see the proper contours. So this is what it would look like. The picture on the right, we're going to send an upper, lower in the bite with the scan body in. Then I take the scan body out and I get a separate scan of the soft tissue. They can see the emergence better, right? Where is everything being directed? And they also have an x-ray to see where my implant is. Is the implant above the bone, even bone, or below the bone, right? And with all those things combined, including a good camera, I have a nice mirrorless camera that I use for all my pictures. And I'll send these pictures and I'll buy some Amazon USBs. They're like $2 a piece. You upload this picture and the x-rays on a USB, you put it in with the case, right? And you can ship it off and you just write on there, hey, please return the USB for me. Because $2 is still $2, right? I want it back. So choose the right implant for the job, right? Whether it's a full arch for the top or a single for the bottom. What I love about this company is I can literally do anything with it. And I have great success rates. So I'd say for this last year, 2 years, I actually had 3 implants fail over the past 800. I think those are pretty good odds. And that just means that I'm saving a lot of money because I'm not having all these post-ops, right? What's the cost of us losing implants? Right? We do understand that after Dr. Doon talked today. So choose the right implant. I did put a QR code for my presentation as well. So please save it. Please go home and make some lab scripts. Please contact us, you guys, if you have any questions whatsoever on real-life application or what do you stock or just want to ask us some questions. Please feel free to do that. So thanks a lot, guys. Dr. Briskie from Colorado Surgical Institute. I hope you guys enjoy the rest of the weekend.